Welcome. Just reminding members switch off mobile phones as the meeting's held in public session, and that will interfere with the recording equipment. Apologies. Do members have any apologies? Okay, a number of items just under Chair's business. Just reminding members that an invitation had been sent to the Minister on Friday past to invite him to attend today's committee meeting to discuss the evidence and facts that he had referred to at the South Down hustings on the 23rd of April, specifically in relation to the links between LGBT relationships and incidents of child abuse or neglect. The Department has advised that the Minister won't be attending the committee today. We are all now aware of the Minister's resignation with effect from the 11th of May. But I do think, members, there are questions that should be answered. I think it is important that we go back to the Department and the Minister to seek clarification, first of all, in the process around who is effectively in charge in this interim period, and they also seek assurances that no gaps will be left in relation to workload or work delivery. We're very mindful that there's critical pieces of work ongoing currently, specifically I think in and around workforce and staffing and industrial action. So I think it's critical that this committee sought those assurances, A, as I said, of who is in charge and clarity around that, and B, can we seek assurances that all work will be progressed and that there will be no gaps. So I'm seeking members' agreement that we would do that following this committee.
Great.
Thank you. Okay, members, another item that's just come to light today has been the European ruling on the lifetime ban on members of the gay community donating blood. I think it would be appropriate, members, given that the ruling needs to be reflected on, but that we would seek assurance from the Minister, or clarity rather from the Minister and the Department, on what that means in terms of the ban here in the North. So I'm seeking agreement that we would write off to get that clarification.
Great.
Thank you. Item 3, members, at the draft minutes from the 22nd of April 2015, which are on page 5. Are members content with the minutes?
Great.
And item 4 is the Food Hygiene Rating Bill. Just advise members that the draft committee report on the Food Hygiene Rating Bill is at page 18 of the meeting pack. And advising members that any typographical formatting errors will be amended at the proofing stage of the report, and asking members if you have any proposed amendments to the draft report. I think we have gone through this clause by clause. I'm taken by that there are no amendments. No. So we now proceed through the report, seeking the committee's formal agreement of the report as drafted. The first item is the title page, Committee Membership and Powers, Table of Contents. I'm putting the question that the title page, Committee Membership and Powers and Table of Content, stand part of the report. Introduction section, I just want to refer members to paragraphs 1 to 10, and putting the question, are members content that the introduction of paragraphs 1 to 10 stand part of the report?
Great.
Consideration of the bill, referring members to paragraphs 11 to 93, the consideration of the bill section, and putting the question, are members content that the consideration of the bill section at paragraphs 11 to 93 stand part of the report?
Great.
And clause by clause consideration of the bill, which are paragraphs 94 to 117, clause by clause consideration section. I'm asking members, are members content that the clause by clause consideration section at paragraphs 94 to 117 stand part of the report?
Great.
The appendices, which are at pages 46 to 50 of the meeting pack, are members content that the appendices stand part of the report?
Great.
The executive summary, pages 22 to 23 of the meeting pack, are members content that the executive summary stands part of the report?
Great.
And the extract minutes, seeking agreement of members for you to approve the relevant extract of today's minutes for inclusion in the printed report.
Agreed.
And the printing of the report, that the Committee for Health, Social Services and Public Safety is content for the report on the food hygiene rating bill to be printed. I am seeking agreement that members to issue an electronic copy of the bill report to all the organisations and individuals who provided evidence to the committee on the bill.
Agreed.
Thank you, members, and thank you for your cooperation. Item 5 is the review of workforce planning in the context of transforming your care. Just want to remind members of a number of issues. So far, the committee has taken evidence from the Regional Workforce Planning Group, the Royal College of GPs and the BMA, the Royal College of Nursing and the Royal College of Midwives. And today the committee is hearing from union representatives. Looking ahead at the work programme, further evidence sessions are scheduled with Allied Health Professionals Federation, the Social Care Council and the Association of Social Workers. The committee office is also trying to arrange for an official from the Scottish Government to talk to the committee about their approach to workforce planning, and the committee will then hold a further session with the Regional Workforce Planning Group, which is headed up by the department, to discuss the range of evidence we've heard to date. At this stage, are there any other stakeholders that the committee would wish to hear from? Are we content? I think it's been a fairly inclusive, robust engagement to date, but if there are other stakeholders, please indicate, or not. Okay. Just want to advise members as well that in terms of further information, which could be provided by Assembly Research to assist with the review, we're suggesting that we would seek details of policies that are used maybe in other jurisdictions to provide workforce planning, specifically maybe for particular geographical areas where recruitment is problematic, and this might be just, as an issue that's come up in certain trust areas. So I think we should look at policies maybe in relation to geography. Policies also that are used to support workforce planning to achieve 7-day working in primary and secondary care settings, and policies that are considered to support workforce planning, taking into account the gender mix, because that is an issue that is coming to the fore more and more, the gender mix of the workforce and associated work patterns, and policies also that have supported the workforce in terms of that policy direction of shift left. So our members agreed that we would seek out relevant research in relation to those other policies.
Yep.
Thank you. Just want to refer members now to page 51 of your meeting folder and page 3 of the tabled papers. Advising you all that we have representatives from NIPSA, ICTU, Unison and Unite are all here today, and you're very welcome, folks, to brief members on workforce planning in the context of transforming your care. I think we have a number of changes. We have Claire Ronald, Vice Chair of ICTU Health Committee. Kevin McAdam couldn't attend today. Jonathan Swallow, Consultant Unison, Anne Speed, Chair of the ICTU Health Committee, and Kevin McCabe, Assistant Secretary from NIPSA. Folks, you're very welcome. We would invite you to make your opening statement, and we will open it up to comments, questions, observations from the floor.
Just give us a moment here. Sorry. We can put our handbags away.
I'm just being told there's a mobile phone that's interfering. So
No,
people
they're
just
all away in the cupboard.
people just check. It's probably members, but then people just check their phones, myself included. Okay, are you?
Yes.
Yourself taking the lead. Okay.
Okay, Anne Speed from Unison, but I'm representing all the affiliates to the Irish Congress of Trade Unions. Good afternoon, everybody, and thank you for the opportunity for us to come give a presentation. An opening comment, and meant with respect to the committee. We represent between 225,000 250,000 people. We're very pleased to be here. We did note the sequence of invitations always seems to start with the medical profession and those who might consider themselves the elite. I'd just like to remind the committee that within our own ranks we have professional, we have nursing, because I noticed that the Royal Colleges, as they're called, were invited in separately. We do have thousands of members across our organisations who are in nursing profession. So perhaps in the future we might be the first in the door, as we not only represent those who work in the service, but we represent the users of the service. And our membership and their families have a huge interest in what is happening to the health service. The second thing is that the Irish Congress of Trade Unions has trade unions affiliated to it. So today I will make observations from a broad strategic or policy approach, but we would also like to remind you that we have our membership in our affiliates inside the bargaining structures. So when Unison is mentioned, when Unite is mentioned, when NIPSA is mentioned, when the CSP, the physiotherapists are mentioned, and my colleague here, Claire, represents all the allied health professionals in the bargaining body. I would represent Unison in the bargaining body. It's to remind you, because sometimes I think people get confused and you look at NICIC as an equivalent to Unison. It is not. It is the house which houses all the unions, and we are all part of the general trade union movement. On the workforce planning developments to date, we have serious concerns about the process. Some 2 years ago, we raised the issue of workforce planning, and we were advised by the department at the time that the only workforce planning taking place was around TYC. We then were informed a little time later that there was a process initiated, or an initiative at the departmental level, which would be to do with a workforce planning structure which would address the tools required to do the workforce planning, and that there was no space or opportunity for us to be involved in that, and we were actually advised it wasn't really relevant to us. We have arrived at a point where a workforce planning structure has been established, the regional workforce group. We have not been invited. We have had sight of some paperwork. There was a consultation document in September, and we have had sight of the evidence presented to you in March of this year, but we have not been invited in. What would concern us as to what's in that documentation is that there seems to be a conclusion on the part of the department, or certainly a perspective, that we should be engaged with at the level of a stakeholder. Now, we believe workforce planning requires more engagement than that. We need to be involved there as partners. And we are regrettably dealing with the reality that the Minister, we believe on advice from the department, closed down the partnership forum. We weren't consulted about it. We were simply told it wasn't happening, and that anything we had to say, we could say in public consultations, and we could also say in the bargaining forum. Now, the bargaining forum deals with agreements to be made and agreements to be implemented and overseen. The Strategic Partnership Forum is about vision, it's about planning the future, it's commitment to that, and we expect to be in there as equal partners. We have not been. And in the evidence given in March to the committee, the department said that they themselves are responsible for setting the strategic vision. I'm quoting from the report. Well, they've collapsed partnership, so we have no role in that as far as they're concerned. The commissioning body and the PHA say that their role is to agree the models of service delivery, and we are now faced with reviews upon reviews upon reviews, in which we have also not, while we may have been invited to engage in conversations, we haven't been involved as equal partners. I think in domiciliary care there are at least 4 reviews. And the trusts are responsible for ensuring that they have an appropriate and skilled workforce to deliver. Now, to deliver workforce planning, we have had some involvement across the trust. It would be wrong of me to deny that, but it has been slow off the mark. It is still in early stages in some of the trusts, And the local involvement, I think, at this stage still leaves a lot to be desired, and it seems to be entirely connected to the strategy of TYC, which is a narrower framework than we would think would be possible or necessary. Because as far as we're concerned, workforce planning should start from the needs of the service as a whole, the delivery to the patient, the journey that they take, and not simply a strategic approach to, for example, shift left, moving from acute delivery to community delivery and all of that. Which is involved, and TYC itself has come in for some serious review and has apparently, certainly with us, and it may even be with yourselves, lost a lot of credibility. So I'd like to hand over now to my colleague, Claire Ronald, who is the Vice Chair of the committee.
I suppose from my point of view, because I also represent some of the smaller professions when we're in the bargaining forum, one of the problems we have with workforce planning and with not being involved at that earliest stage is that what we're tending to see at the moment is silo workforce planning. So instead of thinking of the patient pathway, we're looking at workforce planning for GPs, workforce planning for medics, workforce planning for nursing, and not looking actually at the patient journey. And I know you had evidence given from the BMA and the Royal College of GPs, and they were obviously picking up on the crisis in GPs, and yet it's interesting to note that while we have a crisis in GPs, one of the solutions to that is actually looking outside of GPs. At the moment, around about 20% of the referrals that GPs get and the workload that GPs have is musculoskeletal conditions, and yet the pilot for self-referral for physiotherapy was postponed under TYC and is only now starting off as a pilot to evaluate it when we know it delivers. We know it delivers cost savings. We have evidence from both Scotland and from the areas in England where they've done it that this delivers, but we don't have that joined up workforce planning. We're planning in silos, and if you plan in silos, the answer is always going to be you need more of that profession. You're not going to think outside the box, and if you truly do want to transform the delivery, you need to look slightly differently at how you workforce plan. If as trade unions and professional bodies we are not in at that highest level, we can't influence the decisions that are being made there.
Okay, call on Jonathan now, Swallow from Unison to present.
Chair, I will simply highlight some key elements in the evidence Unison submitted relevant to your inquiry today. We've pointed out the interesting current context in which reshuffles within HSCB seem to slow the delivery of TYC down fundamentally. And we've also highlighted the latest figures where the shift left move in trusts appears to be blocked and stuck, and where new investment at 9 million will hardly buy very much of innovation or change. In respect of your previous discussion on GP numbers, we were amazed to discover at HSCB that their records do not show the number of GPs and related staff per practice funded. And that was admitted as such by officers at the board. So clearly planning is difficult in that environment. As indicated, we've highlighted the different reviews of domiciliary care. Unison is well involved in the HSCB review, but in the current workforce planning initiatives, we have no involvement, nor do the unions. In respect of the questions you put to us in your invitation, we were particularly disturbed to see that the target in last year's ministerial direction for district and community nursing normative staffing no longer exists in the latest direction. It's very concerning as well that a number of previous targets have now been fundamentally slackened off, so any performance comparison in this year compared with last year will be fundamentally misleading when 80% of people are now 65% of people now having to wait 15 to 18 weeks. Just an example of that. In terms of confidence in workforce planning, we remain very disturbed by the statement in the original proposal for integrated care partnerships that there be evaluation including conversion of the entire pathway to a social enterprise. That does not create a confidence environment. Individual members have said to us, am I at risk in participating in this process? That question should not have to be asked. Thus, for the -3% figure you quoted, we would support the PHA view that the growth in demand is exponential now, and therefore that figure cannot be credible. I'd highlight in particular mental health, where the King's Fund analysis shows 50% underfunding, and the latest figures we've seen show a 25% higher presentation rate than in England. With figures like that, the original quoted costs of -3% cannot be achieved. The best you can do is try and contain growth. As far as your specific question on learning disability is concerned, Unison is actively engaged in a complex, tough workforce planning exercise at facilities such as Muckamore, and we continue unconditionally to support the principle of resettlement. Absolutely unconditional support for that correct concept, and then we have to deal at workforce level with the consequences. In terms of day centres, we're looking to take the language of TYC and reinstate the real meaning of hub and spoke, in which the day centre becomes the leading light, the leading source of care in an area, rather than being marginalised and downgraded. That also has major workforce planning issues. Thank you, Chair.
Thank you. And finally, Kevin McCabe from NIPSA, who will address in particular what's happening with social workers and administrative workers in the system.
Yes, Chairperson, members of the committee. In terms of the grades or disciplines that we would represent, starting with social workers, we would want to ensure that there are a sufficient number of social workers to meet the requirements set out in the 10-year social work strategy, which was launched by Minister Poots. There's been evidence of certainly improved work processes, multidisciplinary working and integrated working across the service. But in terms of the strategy, which does deal with flexible working and 24/7 working, we think it's very important that proper analysis is given to the number of students, placements, demand and supply would all need to be analysed in terms of matching the needs of the workforce with the aspirations within the strategy. The second area is in relation to admin and clerical staff. Again, I mean, for example, these number 3,500 in the Belfast Trust alone, but it has always been our view that such staff should be considered frontline staff, because in their absence, we're very clear that clinics would not operate, consultants would not be able to carry out their duties, and there would be a systemic failure in a whole range of services if not properly resourced. There's evidence to show that they have been crippled by vacancy controls, and we would ask the committee to give some consideration that they're the unsung heroes in many ways in terms of the support that they provide to other clinicians and to keep the service afloat. Finally, social care workforce, which ourselves and Unison and other sister unions would have members, we believe they're being targeted very much by privatisation, value for money audits, which are twin themes of procurement and privatisation contained within the Vision for Action TYC consultation document. And it is our view that we have seen reports from the likes of the RQIA, the Regional Quality Inspection Authority, and others that where work is being outsourced, this has led to a decline in standards. And given in some areas we have seen award-winning quality assured professionals replaced by less skilled, qualified or experienced staff. And again, that's something I think that needs to be given due consideration. And that would conclude the NIPSA submission.
Okay. Thank you all, first of all. Probably the first question is that, increasingly there's a sense that TYC is questioned as a viable strategy. It's called a vision without action. I certainly have my own views that it was the right policy direction, but it wasn't validated by any strategic evaluation in terms of either investment or outcome framework in terms of health inequalities. So is it dead, or if it's dying, can it be resuscitated?
Jonathan, would you like to answer that?
I think it's going to go through a 3 to 6 month hiatus with internal restructuring of roles in HSCB, and there needs to be more look at what the funding has achieved. I'd highlight in particular to the committee the note I made of paragraph 3, the proposal to produce a 99 original proposals update could be of great interest to this committee. I think the funding environment has now become at the cusp of risk and risk to patient safety. The committee may wish to know that of the 90 million cuts demanded of trust by HSCB, only 60 million have been taken forward because the remaining 30 million were ruled out by the Public Health Agency as compromising and risking patient safety. We have currently got savings plans that rely on the falling price of fuel and on the misuse of vacancy control as a low-hanging fruit saving that compromises performance targets. So in that environment, we see the future for the current TYC process as very challenging.
Did you just say that 30 million of those proposed cuts were a risk to patient safety?
Were judged by the PHA to compromise or create risk, and were therefore taken out of the trust savings plans.
Yeah.
So trusts have put forward 60 million of savings when they were originally asked for 90 million. But we found the actual process, Chair, by which the situation was so desperate that such proposals had to be brought forward, that PHAs had to say, no, you shouldn't do that. It's a very concerning process.
And that should be of concern to us all.
Yes.
When you get an analysis that you're talking risk,
We are
potential
currently
risk.
seeking, Chair, for detail of the 30 million that were taken forward. It hasn't been made available yet.
We're currently seeking the trust delivery plans as distinct from their savings plans post the publication of the commissioning plan by the board, and we'll have a closer look as to see what the actual practical on the ground implications are going to be, and I think close scrutiny of those delivery plans should be the business of the committee as well.
Yeah, no, that's something that we certainly should and can influence. And I'm staying with the overall context because, you know, I think that this is the critical part, not only in relation to workforce planning, but in relation to transforming your care generally. And, you know, it does seem to be that increasingly there is a growing consensus, I think, that at the heart of this problem we have a flawed system in the way the system is currently configured. And, you know, we do see a system that has lack of clarity in terms of roles. We see a system that is overly bureaucratic, that there is a lack of transparency, that decisions go in and out through a system, and there doesn't seem to be a lot of accountability. And, you know, there is an increasing sense around decision-making processes and good use of public money in relation to that. So is that your sense as union representing huge sections of society, that the system itself as it's configured is flawed? And if so, what needs to alter in it to ensure things like workforce planning actually can be responded to in terms of the needs that exists?
I'd ask my colleague Claire to respond to that.
I mean, I think I would agree with you that what we are seeing on the ground is that it's a flawed system and you don't know how to get into the system. And certainly the feeling for us as trade unions is we are being actively excluded from the system, that's even the Regional Workforce Planning Group, despite asking from the very earliest opportunity, can we be at the table, can we be involved in these decisions? Now suddenly we're down at a stakeholder level and not able to influence to the same level. If you speak to staff on the ground, many of whom will have good ideas, their answer is we don't know where to take it. Who's accountable? Who do you go to? Is it integrated care partnerships? Is it commissioning groups? As a physio, are you going through an AHP group? You've got so many levels to go through who can reject what you're suggesting. And then even, as I say, the self-referral pilot within physio is a classic example, which has been demonstrated to release savings elsewhere. but we had to jump through hoops and then suddenly it's withdrawn. South Eastern Trust were in the preparation stages, ready to sort of start rolling, and suddenly it's withdrawn. It's no longer in the plan, despite being in the commissioning plan, also being in the DUP manifesto. So you just feel as though you're running on a treadmill and constantly coming back to the same problems, and things that we highlighted 2 years ago are now coming, you know, that you asked about, you're back asking about again and going through the same treadmill.
And how, and I'm going to, because I know all our members have indicated, how, in your view, does commissioning change?
Chair, Unison last week spoke briefly at the NICON conference. We set out 3 principles for radical reform: bringing the system back to financial sustainability, ending health inequalities, and raising general performance. We had some key principles underlying that, which will include the end of the commissioning provider split, the legacy of direct rule, single point leadership and accountability, so that somebody has to be responsible, the end of all outsourcing and privatisation, and going back to previous performance targets, not those sanitised in the latest ministerial direction. I will be happy to arrange for that press release to be circulated to all members of the committee.
That'd be useful. Just finally, for myself, the 3%, and Jonathan, you had referred to it, the 3% reduction in staff that was alluded to as a target within, not a target, but a component of TYC. It has now been discovered that it's actually, it was an assumption or a working assumption, and you had indicated obviously that, you know, it's actually an increase in terms of staffing and of workforce that you would need to deliver TYC. Do you have a figure on that? Do you have an estimate on that?
Not at this stage, Chair. I mean, I think we know that in every aspect of the service, demand is increasing. So we need to model that increase in demand. I've cited already the increase in mental health. We've seen the desperate state of statistics in A&E units. So I think we need to move away from the current approach of the department, which is to say in the commissioning plan, this is what we're doing with the current budget, and go back to the correct approach, which is to model increasing demand and unmet need, and then say what the answer is. We are very concerned at the culture we're seeing in the department of simply cutting the coat to the cloth, rather than actually looking at unmet need.
I would just like to add 2 sentences. We said when TYC was first published that this figure of 3% was financial. It wasn't based on an estimate of how the service would change, and there was nothing behind it. We've been proved right. And secondly, within the bargaining structures to which our affiliates are involved, at the last meeting of the regional bargaining body, a proposition for voluntary exit was put on the table. And we said, where's the analysis? How does this fit with workforce planning? Where do you think the voluntary exits are going to occur? We said, until such time as we get proper and coherent analysis of where the service might do without staff, and we believe they're crying out for staff, we'll not entertain that until we've insisted to come off the table. That is the kind of haphazard approach you're having at departmental level, which is filtering right down through the structures. And we have a perception of committees and bodies bumping into each other, cross-referencing, and a whole load of people doing the same thing, and a whole load of money being spent on it. That's our sense of it.
Finally, I said finally the last time, but I'm going to use my position as chair, but are Scotland moving in the right direction?
Here's my colleague here. I would ask if she has a co-location responsibility, so she's experienced within the Scottish Health Service.
It's really difficult because I've worked as a physio in Scotland, so it was kind of what I knew. So when I took on the post, because I covered part of Scotland and Northern Ireland in my role, I assumed when I came to Northern Ireland it would be a very similar situation, and I have to say my learning curve, I still, 4 years into the post, still don't understand clearly where decisions are made, and it's constantly changing within Scotland. The one thing I would say that is good is partnership is embedded at the very heart. The amount of meetings we have, the ability to just get into the department and chat to the department. As soon as groups are set up, the very first thing they do is right out to the staff side and say who is the appropriate person to sit on this from staff side. The other really interesting thing, both in Scotland, Wales is slightly different, but they both took a stand against privatisation, which we haven't seen yet firmly embedded here, a firm stance that we will not outsource the NHS, and that's the other fear within TYC. The committee structures and the funding in Scotland, to me, seems slightly easier to follow. So you have the minister giving the money down to the health boards to make the decisions that are appropriate at the health board level, tying into the targets that are being set. Whereas even following the money and who decides on who gets the money and where the money goes, and so much short-term funding that seems to be going on. So I think you could learn from Scotland, but you have to be aware that it's a very different structure.
But is it
within
suffice to
Northern
say that Scotland moved back to the kind of traditional NHS
Yeah, we
cooperative?
have no purchaser-provider split, and they've brought an awful lot of private care back into the NHS, and that's the big move, is constantly bringing it back in. I mean, the Golden Jubilee Hospital is a prime example, which was a private hospital that was bought back by the NHS. Even looking at the new Glasgow Hospital that's just opened, I think they're nicknaming it the Death Star and all sorts of horrible things, but state-of-the-art hospital that was funded not through PFI. There's no loans to be paid on that. It was a government-funded sort of building, so that there's not a loan outstanding on it that's going to drag us further into debt.
If I could remind the committee here that I think I'm right in saying that the Assembly did pass a motion, I think it was brought by Conal McDevitt,
Yep.
on the issue of
He was it,
privatisation, and that if there were to be further strategic decisions made about any of the public sector, that there would be a review by the Assembly or the appropriate committees. I think it was something like that. And I'm wondering, has that motion or that decision by the Assembly disappeared, because it should be the mechanism by which you do your business?
Possibly.
Okay, have Kieran next.
Thank you, Chair. Well, thank you very much for your presentation. But can I start by acknowledging your comments, Anne, at the very outset? And let me say loud and clear that I have 100% faith in you and in your colleagues here. And I think that you should be up at the front in any negotiations to make sure that the people that you represent get nothing but the best. So I want to say that at the outset. I have a number of questions here, and self-referral, you mentioned there. Self-referral was to have been implemented, as I understand it.
Yeah.
And we were all excited about it. And for some reason it has not been implemented. But as far as I know, Chair, we were informed that it was coming back somewhere.
There is a
sometime,
pilot start.
There's
Yeah.
a pilot starting in South Eastern Trust.
which we are as disappointed as what you were, that this has been knocked back for some time. Anyway, one of the terms of reference for the committee's review is to examine the department's approach to involving staff and staff-side organisations in the workforce planning required to implement transforming your care. How, I mean, I know the answer to this, but I'm going to ask it anyway. How would you assess the department's approach to date?
Abysmal. Completely unengaged with, the majority of its workforce. Without any clear indicator of what exactly, what the next steps are going to be. We do note that there is some engagement at trust level, but because we haven't been engaged at the centre, we don't know what the framework in which the trusts are approaching this question is, and it's very much, I think, focused on the immediate needs of the trust and maybe dealing with issues like vacancy control in reality, rather than the strategic overview planning for the medium to long term. So it's been non-existent, our engagement or our involvement, and we are very critical. And I repeat the point, why would you close down a partnership forum when such a significant dialogue is starting on workforce planning? It makes absolutely no sense. In our opinion, and I choose my words very carefully because I don't wish to be disrespectful to the department or its officials, but it shows a complete lack of understanding between strategic and policy engagement and actual negotiation and bargaining, or That's at best, and at worst, it indicates prejudice, that there's no place for us. And we're not sure which of those two opinions really holds sway.
Oh, well, just following on from that, last week we had representatives from the nursing people in when we had the midwife.
Some of the nursing, if I may.
Right, okay.
comment.
I did ask during my opportunity to question those individuals, did they have any faith in the people that were running the department? I think that was the question I asked. Do they, who's running the department, know what they're doing? Could I presume from your answer up to date that that's probably not?
Well,
I don't know what they're doing.
I wouldn't have a lot of confidence. I think individually they're probably decent people working in the department. They all need their employment like everybody else. But as a coherent public, as a coherent arm of the executive and of for delivery of service, I don't think it's acting in a coherent manner whatsoever. And then, of course, we don't want to gild the lily. It's had two ministers leading it now, and well, there's a job of work to be done there in terms of, the next minister who steps forward really needs to be there for the long term and be there to give good guidance to the department.
Yeah, you want to speak?
I was just going to come in briefly on that. And do the people in the department know what they're doing? I think even in their own evidence, they highlighted that they had to have Skills for Health coming over to do training for them on workforce planning. And that's quite a big gap within the department if they didn't have the skill set and have to build that skill set up when we're how many years now into TYC, and they're only now looking at the skills for workforce planning, which is quite frightening.
Right, okay.
I suppose a crude way of saying it would be they're all over the shop.
Okay. Right, again, a similar question. Is it clear to you who's in charge of the workforce planning? Is it the department, is it the board, or is it the trusts, or are they all over the place?
Well, they all say they're in charge there according to their evidence. Kevin, would you like to answer that?
Yeah, right, and your confidence in them delivering?
Well, I think, in terms, we all know that they have discrete functions, but I want to sort of tie my points to the Chair's original proposition about, I think in terms of leadership and outcome, you need to know where the strategic direction has gone. Just last week, you're getting mixed messages, and again, that leads to confusion in terms of where are we going in terms of strategic direction. You've the Health and Social Care Board Chief Executive saying it's still the only strategic direction for the department, but it needs rebranding. We've heard politicians calling for the scrapping of TYC, and we've heard other politicians calling for a review of TYC. And again, it's very clear that it was never based on any it's a vision and it's a plan drawn up by people, but it was never underpinned by legislation, never underpinned by any strategic sort of analysis and agreement that is the way forward. I don't think fundamentally in all the submissions that were made, anyone disagreed that a shift from acute care to community isn't a bad thing, but it needs properly resourced. The shambolic outworking of TYC has meant that transitional funding has not even been met, let alone the 83 million. And you've got to then join the dots together in terms of if the funding's there and that you can move and you can see the strategic direction, then I think you can start to look about workforce planning and numbers. But I think to answer Mr McCarthy's question, at the moment, I think bodies function, the department functions separately from the board, which functions separately from the Public Health Agency. Of course, there has to be some coordination and working together. But at the heart of that is, I think, the big whole of the general direction of healthcare and what is the right model. And I do think Scotland is one to look to, but I think it does require all of the stakeholders to come together to reassess or certainly review where we're going, because if the funding's not there, how do you plot the way forward?
Can I just jump in there?
Kieran, are you okay if Kieran comes in on this? Yeah.
Maybe this is a bit leading, but as you've rightly, I think, characterised that there are different approaches now to the TYC concept, is there a danger that, it was at least on paper, it at least had been consulted on, it at least had 99 targets, and if it is now morphed into some vague conversation about transformation, we won't necessarily have anything to pin the measurement, the finance, strategic direction on. So would you share a concern that if TYC was to disappear in that context, either through what Valerie Watts was saying last week, that it was in the context of 2011 and things have now changed? Is there a danger, really, is what I'm saying, that the construct of TYC, as it was originally, disappears, and with it, the strategic direction?
They tell us it's mainstreamed and what measurement. Jonathan, do you like
I
to...
would like to see the detail of the statement mainstreamed into general commissioning. That has just been a statement in the last few weeks. There's no detail to unpick within it. I would like to see an end to the sanitisation strategy of the department in actually concealing performance information, changing targets. This general approach totally weakens the process. And we have to look at how many people are needed to do the work. That is the essence of workforce planning. We now have a statement that normative nurse staffing, including the critical issue of district and community nurses, is now not to be achieved till March 2016. The HSCB report said we have no investment. Without those issues being resolved, TYC becomes a series of projects, lowly funded, that don't make a visible difference to the critical issues we face in health.
Just to finish off, I mean, and given what has happened this week and the loss of another health minister will not help any of us in the cause and the direction that we're travelling. I'm sure you'll agree. But finally, yourself, you mentioned that you weren't represented on the regional workforce planning group. Do you believe that that would be hindering communications between yourselves and the department and indeed the workforce? Because you're not on that.
Oh, absolutely. I mean, if somebody is sitting, there's a body of people with authority and with power in the health service, influence and budgets, and are sitting planning the future, and we're not there. And we represent between, all the organisations, the medical people, our own membership, like there's 60,000 employed, and I think all of the professional and trade union bodies, we must represent more than 50,000 people.
Yeah.
Of that, the affiliates of the Congress would be the largest bloc, together with the RCN and RCM, and nobody's having a conversation with us.
Well, that brings me back to the question, do those at the top know what they're doing? Because surely you would be the first people. I think last week we heard from the other representatives that they weren't on that group either.
The RCM and the RCN, yeah.
And surely the people at the top would be you would be the first people to be brought in with your own hands experience.
Well, you see, when you have bureaucratic layers and you have layers upon layers, there are people who are employed within those structures who believe they do know. And they take it upon themselves to make the decisions. So there's a whole load of people going around think they know best. And that's what happens when you have a bureaucracy which is out of control. They believe they know best. And that's a difficulty. And unless you take the evidence and unless you take the experience of the people who are actually delivering the service on the ground, how can you evaluate or come up with the plans for the future?
Finally, Chair, could I ask Jonathan, you mentioned Muckamore Abbey, and I have a particular interest in how Muckamore Abbey finishes, as it were.
Yes.
Can you tell the committee, are you satisfied with how it's going? There are obviously still patients or clients in Muckamore. Are they being looked after the way they were supposed to be looked after?
Well, as far as we can tell, the clinical standards remain good. The principle of resettlement, as I indicated, Chair, is unconditionally backed by Unison. So our members are going through change processes, quite fundamental processes, because people aren't going to be there. But it has to happen, it needs to happen, and as a union, we fully endorse the process. We've seen no issues, had no reports of any failure of clinical standards or care.
Well, I'm glad to hear that, Chair. The deadline, I presume, has gone, because there was a deadline to have that completed, and it's not been done. Are you still happy that there's no push to get people out into places where they ought not to be? That's my concern.
We
We're keeping
suggest,
a
Chair,
close eye on
it's
that.
proper and professional, but we have to follow the pace of it because of the workforce planning issues.
Yeah. Okay. Thanks,
Okay,
Chair.
thank you. And I have Pam next.
Thank you, Chair, and thank you for your presentations today. I'm just really following on from Kieran's last point there. As part of the shift left, under TYC, the department has told us that around 25 million has already been shifted from hospital services to community primary services, specifically in the area of disability and mental health resettlement. Do you have information, we've heard from the patient side of things, do you have information on what the impact of staff has been?
Well, I wouldn't have an in-depth knowledge to share with you today, though we did get a presentation. We have this structure called TYC Engagement Forum, and what happens is the directors from the board come and they give us a presentation on what's happening. In the mental health area, it probably would be the better of all that has happened across the service in terms of attention to, to dealing with the deficits or dealing with the change. It probably would be one of the better areas, but there are still difficulties as we've outlined in our presentation. But we have not yet, even though we have asked 3 times for a breakdown of where the 25 million was spent, how it was spent, where it was applied. So when we go into these rooms and we hear these fine presentations delivered by very pleasant people, we look for the detail, because it's the detail that matters, and there's no breakdown yet on what has been spent to date. Equally, if I can slide something in here, we also asked for a breakdown on the savings which was to be accrued under shared services and the payroll issue and the continuing debacle with the payroll issue. I know that's for another day, so we haven't got that information either. So there appears to be a lowering of the importance of engagement with the representative bodies, which seems to be percolating right down through the structures and across all the bureaucratic layers. I think everybody's under pressure about budget deficits, and the directive went out, balance the books, and everybody's scurrying around doing this. But in the middle of all of that, the important work that we undertake in terms of, we consider ourselves to be the guardians of not only our members' interests, but the service that our membership, 250,000 of them, actually receive. And it's just not happening. We're not getting this information. But I will happily seek further information, and I will send it to you, because I think it's an important figure we need to deconstruct.
Sorry, if I could just compliment what my colleague was saying. I don't think there's an issue there in terms of the mental health, because by and large the Bamford review was endorsed, but unfortunately only some of those recommendations are contained within TYC. But Bamford universally was felt the right way forward. And come back to the point that Jonathan had made, even within those 99 recommendations under TYC, a lot of them were already programmes of care were already implementing. So you're saying, part of that has already been in place in terms of programmes of care in the direction that they believed that they had to travel, subject to funding. But again, I noted quite a number of organisations that said Bamford was the way forward, but it's costly, and you're seeing partial implementation of that.
And just to add, Chair, the crucial figures will be in the 2015 commissioning plan, which is currently being exchanged in draft between HSCB and the department. Its final approval by HSCB is on the 14th of May. We will be seeking to make comments during that meeting. as to whether it addresses the issues, for example, raised by members here about mental health funding. The last 3 plans have done nothing to address the 50% underfunding and the 25% higher presentation rate. So it will be a key element of our scrutiny of that plan.
Just to follow up on that, could I ask then, so would it be wrong to presume then that there hasn't been a big impact on the staff in that particular area?
Well, I think I couldn't give you hard evidence today about the impact on staff because we're trying to gather it in. I think Jonathan's point about there was initial underfunding anyway, there in the first place. I think that there has been some shifts, as they say, and changes, and some of them have been positive rather than negative. The impact on staff, we'll get the statistics from you, but we're still trying to find that out ourselves. And because we're not at the table on workforce planning, we can't really see closely where the detail is, but we'll get that for you.
Okay, thank you.
Yeah, because I think it's about the impact issue. If you have shifted from hospital to community, you know, what does that mean in terms of staff, or staff now not working in a hospital setting and are working in community, and those kind of issues in terms of that shift as well. So it'd be useful if you can pick up on that information. I have, no, Joanne's left. Paula's next.
Thank you, Chair. And can I first of all register or declare an interest as a member of a union, and still a member of a union, and thankfully I'm still a member of a union, because in 13 months' time,
we're delighted to have you
I
in
may
our
require
family.
that union in 13 months.
You may be
if
happy to
I'm
have
not
you in the
re-elected
family.
and I need to have a journey back into the Northern Trust. I'll just stay with that in the meantime. My career break will be over by then. And just to pick up on the point, first of all, Kieran had said about unions being present and being part of the discussions. I wholeheartedly agree. I remember when I was elected in 2011, had freshly left an acute hospital setting and had become a member of this committee, and hearing briefings from the department, from the heads of trusts, from the board, and sitting here many times thinking, I don't recognise that, because I know that didn't happen when I, worked in Antrim Area Hospital, or, that's not right, or that's not, where are they getting their information from? How's that information being fed up? So without the likes of you people, you're actually feeding the information from the ground up.
You're getting the glossy version.
I'm at a loss as to where they actually get some of the information from, because some of it was totally off the wall, completely off the wall. So yeah, I do believe that there are many instances, I'm not saying in every instance, but many instances where the unions most definitely that would be required. Can I also say a thank you to the two members on either end for bringing up the word social work, because very much that is, when we talk about allied health professionals and other parts of the service, we forget quite often about social work, and I know how much pressure, going back even 2011, that service was under. And that's whenever, I know when the chair had brought up about the 3% reduction in the workforce, and I remember, thinking, how on earth could we have sustained a 3% reduction in that workforce to meet the needs in the community? It just wouldn't have been able to happen. Now, I just want to go back then to what we had heard last week from the Royal College of Nursing to do with the last 4 years and the reduction in our district and community nursing, and how that is totally not in line with TYC. And we also heard from the BMA and the wonderful initiatives that we have now of treating people in their home, or acute care at home, and all of these wonderful things, which are fantastic and which are in line with TYC. And you brought up some other, and I know, Jonathan, you'd said actually when you were giving your briefing how most concerning this was. You'd also mentioned other disciplines within our health service. Have we any evidence to back up that those other disciplines, has been a decline in numbers and the exact disciplines we need in our communities to bring transforming your care forward?
Well, It takes a little bit of time to decipher the workforce statistics that are published because I think the headcount is hiding the fact that there are bank, there's agency, and there is definitely a decline in the number of permanent employees. There's an increase in people carrying more than one contract. You have had evidence before you about the cost of agency working, which in itself becomes a burden. So our empirical evidence, our experience is in every workplace there'll be somebody missing. And those hours will be covered by either bank, agency, or don't use overtime except in the ambulance service. So that'll be the case. And then there'll be a problem with health workers having to extend their shifts, cover shifts that they shouldn't be covering. So there's a lot of practices which are in there, which if you took a microscope to, you'd say, oh, there's a risk factor there. You probably know that a number of organisations are engaged in industrial action or action short of strike, and one of them is to do with the trying to illustrate where the actual staff shortages are. So we've started a process of log-in, and what we're doing is we're logging in the extra time that nurses, service support workers, catering, portering are all using over and above their shifts, and we're going to compile that evidence. Now, it was, and present, we bring it before the committee. It was previously notified in the survey in 2012. I think 49% of staff actually work over their time. 49.
I can assure you that when I worked in Antrim Area Hospital,
Yes.
in the social work team,
Yeah.
none of us left at 5 in the evening.
Yeah.
That just didn't happen.
Yeah.
That was the time when you got your write-ups done.
Yeah.
It was after, I know that.
Yeah.
I know the amount of hours I gave personally as well.
Yeah.
That were not paid for.
And-
so many disciplines right across the board.
So we're trying to look at the latest figures and deconstruct. The other area where we would notice it is that when we applied to have representatives released for training, and very necessary training, to do with health and safety, for example, which is a legal obligation on the part of the employer to release people. They can't be released because there's a shortage in the particular ward, in the particular workplace, and people can't be released. So there's a lot of empirical evidence in terms of the hard stats. I think that's the job of work we're doing, we're
I think it would
undertaking
be
at the
important
moment.
to get those figures.
Yeah.
For across the disciplines, because all of them
Yes.
play such an important part in that complete
Yeah.
multidisciplinary
Claire wants to add
working.
AHPs.
I was going to say the other thing is that the things that are difficult to measure and to get a handle on, which within sort of our own profession of physiotherapy, it's the amount of posts that are on non-recurring funding and have been for 2 or 3 years. So these are services that trusts are relying on, looking at likes of the A&E services and physios in A&E, which is providing a benefit, but they're all on non-recurring funding. So you've got staff who are seconded out from other posts to do this, which then means that we don't know. So even trying to measure staff, you don't know how many are substantive staff, how many should be funded. A fundamental part of workforce planning, we don't even do workforce counting properly. And then the other thing we're very poor at measuring is unmet need. I mean, we've got physios who are working to prioritisations that they would do if there was a flu pandemic. And that's what they're working at on a Monday to Friday, and then being asked to look at 7-day services. You cannot take a service that can't function over 5 days or is functioning on crisis levels over 5 days and expect it to do 7. Now, we know that there's a need for that, but we've not got that strategy discussion around about, well, what do we stop doing? What do we do more of? Where do we put our limited, finite resources? And when does non-recurring posts have to become recurring and part of the establishment?
And I think there's another issue, Chair, but just, and Kevin, I know, well, if you pick up on this, I know amongst social service, or social workers, as well as other disciplines, about protected workloads with our students and all of that, and how quite often that goes astray. And those students in whatever discipline are used as part of that model.
That's right.
And that's unacceptable. It's unacceptable for the client, and it's equally unacceptable for the worker as well. So it just worries me sometimes that when we look at figures and we look at numbers, that we're not seeing the full truth.
Yeah, you're masking
Yeah.
some of the.
You know, so I think that's, again, when we're looking at the figures and we're looking how community, whatever discipline, has maybe reduced, we need to look at all of those in a different, we need to look at all of them differently, because I think that there's definitely faults there within the system.
The one thing I would have to honestly say is that the only area I have seen any attempt to have any, and again you could call it silo planning, is the Chief Nursing Officer did launch a review, and there was a participation of myself from Unison and the RCM and the RCN, and that's where the deficits in the nursing workforce, particularly in relation to TYC, really came to the fore, and she has actually supported an argument for new post creation and funding, and I think has pushed that through. But that seems to be disconnected, that piece of work, and there was some serious work done by some of the Department of Health staff. I wouldn't like to, have a totally negative view of that world. They did some good work, but it exists by itself. It's not connected to the broader process, or at least we don't know if it is, because we're not there. But there was some planning at that level, and apparently the 200 vacancies of community and district nurses we've been given a promise that they will be filled, and that funding is coming through, but we haven't seen sight of that yet.
They haven't given you a time frame on it either, I assume.
No, not that I'm aware of.
And Chair, just to comment on social work, I'm very concerned not to see in TYC any serious consideration of client ratios. And what I did see last year was the HSCB calling a market sounding exercise on intensive family support, specifically saying the providers would have a low client ratio. The reaction of social work trade union members faced with the current high client ratios they have now was not particularly polite. I'm pleased to say HSCB have withdrawn that proposal. But if we are going to do serious planning in an area like social work, we have to focus on reducing the client ratio.
Right, okay. And I sometimes think as health professionals, I was going to say health professionals need to look at unmet need. So they do, and not think of unmet need as a negative as such for their profession, because it shows the reality and the truth behind that. That they can register, this is an unmet need because we don't have the staff to meet that need. And it's not a negative, but it's always seen as a negative. It isn't. It's just telling the truth.
Yeah, there's tendency for health professionals to put the patient above their own, and I think we see that then in the rising sickness absence levels that often mirror that as well, that staff are just getting totally burnt out from trying to do everything.
Thank you, Chair.
Okay, thank you, and I'm glad the Deputy Chair keeps me on my toes, because I should have declared an interest as a member of the union as well. It's cooperation in government. Next,
And that's not a negative. That's
Oh, no, absolutely, it is a very proud member
Take
of the
your
union
point.
as well. Rosie's next.
Thanks, Chair, and thanks very much for the presentation, for coming here today. Can I ask you about the gender issue? And the Unison paper states that the workforce is substantially female, and that this shouldn't be used as stereotypes into part-time work. Can you talk a bit more about that?
That, Chair, is simply a reaction to what we hear as stereotype decisions, particularly about the increased participation of women in certain professions, including the medical profession. We were concerned at any direction of that. Simply, the statement is there from us to say it is, above all, a female workforce. that we must not think that can be exploited or manoeuvred in any particular way in terms of a workforce planning process. A full-time equivalent remains a full-time equivalent.
So when you say exploited, then what would that mean? I mean, how would you see the workforce if it was regarded as, you know, substantially women? How would you see exploitation happening?
Well, the case study we would first of all bring out is the terms and conditions of the totally gendered home care workforce in the independent and private sector, who are not, in many cases, even achieving minimum wage. We've just managed our first successful HMRC intervention to get them back pay, who are faced with 0 hours models of contracts as a gendered female workforce, where, for example, they're disciplined if they go and work for somebody else when there's no work for them. Again, we've just won several cases on that, the exclusivity issue. And the isolation and circumstances in which they have to work. So the contrast between a properly paid and structured in-house home care service, which has about 40% of the work, and what's happening out there with this workforce that never seems to be included in workforce planning processes in the private and independent sector is fundamental, and it seems to rely on gender stereotypes.
Okay. Yeah. Okay. Well, can I ask you then? Do you think the workforce planning at a departmental level is taking into account the gender mix of staff and the associated working patterns?
I think we need to be at the table first, Chair.
Yeah, we don't know.
The whole content of the evidence today is not being at the table.
Yeah, I know, and I agree. And I mean, that's a huge issue, and it's. I mean, I agree with you totally that you should be there, but it might be obvious. But why do you think these are excluded from that process?
Well, I'll repeat what I said earlier. I think it's either a misunderstanding of the importance of having trade unions as partners and not just as people at the end of the line, you know, some distant stakeholder that you talk to, you know, 3/4 way through the process. Or there's a prejudicial view, which is that we're really only there for, you know, solving problems rather than contributing to solutions and being part of planning for the future.
I think the other problem can be when you're not involved at the very earliest opportunity in making decisions, what you tend to get stuck into a pattern of behaviour is we see the problems as they're then on the coalface, so we then have to confront, and you get stuck into almost a battle because you're seeing it at the later stage. So I don't know whether we're perceived by somebody as being the troublemakers, whereas if you're involved at that very earliest opportunity, you don't get to that stage of being in conflict.
Could avoid it.
And I think that is the problem, is we've been so long that we've been excluded from the process that you get into a conflict situation where you're always seen as being adversarial to the department. And it's not where we want to be. It's where we have to be because of when we're getting the information.
And I mean, I think also that people who work at the coalface, people who work on the ground, have got ideas and contributions then that are being missed because they're not being included in the discussion, and that's so valuable.
We on the trade union side, and I think in particular, I think Eunice and Jonathan has been involved in partnership projects which arose out of a problem being identified, and instead of us going into a room and having an argument about, you know, keeping the lines drawn, looking at what and say, how can we collectively contribute? We've had some good partnership projects, and for example, in the laundries in the Southern Trust was an example you might...
Yes, the laundry was under threat of being tendered out and closure. We turned that round. We've put in a partnership. We have measured major improvements in staff welfare and health. We have better production. We have even got the windows painted so it's nice and attractive for nursing homes to bring us their laundry. Sometimes partnership can be as fundamental as that. But I think the issue that I have difficulty with is if I look at the general practice of the Department of Health on equality, it is very poor. For example, it was a few years ago under a different minister, we discovered their equality unit had screened 200 issues and screened 200 out from any assessment. That was a stunning bureaucratic process. If members were to look, for example, at the recent departmental consultation on paediatric cardiology, they would find a tick box equality model and 4 lines on human rights on such a fundamental issue. So I think if we're going to pick up issues like gender in workforce planning, it's incumbent on all of us, including the department, to raise their game on their practice of equality rather than simply seeking to squeeze it out of the issues.
I think I would add that over a period, say, of the last 7 years, and I've been involved in this field for 4, the equality officers at the level of each trust appear to have become less and less important, less visible, and sidelined. So that when I first met a group of them 4 years ago, they had a very kind of hands-on engagement with the trust delivery plans, strategic planning within the trust structures. I don't see that as visible as it has been heretofore. So I think there are problems. It's like, you say, oh, sure, women have equality, what do we need to be talking about? It's that kind of mindset, whereas with equality you need to be ever focused on, because populations change, people change, practices change. You always need to have the mechanism to review and assess. I think that's been downgraded. There's no doubt the trust managements are under pressure in terms of, balance the books and do this and don't do that, but at the same time they've obligations under the, the foundation of the NHS, the guiding principles, to actually make sure that none of this is lost in the mix. That's our general experience.
Yeah. Can I just ask one last question? Would you say that it's been raised here before and today also about people doing work beyond the hours that they're paid for? Do you find that there's an over tendency to see women doing that? Or is it in the type of work that maybe more women are inclined to do?
Well, the point is the workforce there's more women in the workforce, so by that very fact it would be women doing that.
But do you think, would it be as likely to be the same if it were more men?
Sure, the world would change if there was more. I can assure you that, let me tell you this, the living wage would have been well established. People wouldn't be existing, this is a personal view, people wouldn't be existing on minimum wage, and there would be a lot more done. I think that it's in the nature of women's commitment, the women who work in the health service commitment. We're caring, I'm not saying men aren't caring human beings, but by our gender we are, and we tend to commit and give good measure and give a very high level of participation and commitment to our work. I think there's a few academic exercises and bits of research have been done that the public sector generally delivers better equality on a gender basis than the private sector, and so we would guard our public sector employment very, very, very closely. It's very important for women in this part of the world that they continue to work within the public sector, because it gives better support to them, and women give better commitment to the public sector.
Okay, can I just ask one last one? You expressed concerns about a direction towards privatisation. Do you feel that that's...
let me tell you, as the lead negotiator on for trade unions in the bargaining structure, that all of the trusts have shifted from a predominance of direct delivery, for example, on domiciliary care, to a minority ratio, and that is very serious. And the drive to continue that is underpinned by the Balance the Books directive from the department and the trust deficits. The difficulty is then that the people working, the women working within the private home care sector, as Jonathan said, their conditions are 50% of what the women workers have in the health sector. No minimum wage, no mileage. Do your 15-minute call and appear, 5 miles down the road 2 minutes later. This kind of thing, and it's very worrying. The drift towards privatisation, and I would think the Assembly here and all political parties could make a huge contribution in stopping this drift. I mean, we could here play a leading role in defending the NHS and making sure that it isn't deconstructed in Northern Ireland, no matter what happens elsewhere. But we could look to our colleagues in Scotland and in Wales. There's a bit of a fight going on there as well. But it's very serious. So that's why I mentioned the decision in the Assembly some time back. You have a mechanism to review it and to look at it. I think, Jonathan, did you want to add something?
Very quick comment. To give an example relevant to the scope of this committee, but outside health, the fire service is now tendering out the jobs of the 50 women who get 4 hours a week to clean the volunteer fire stations. Now, there are no savings. This is a bizarre proposal to apparently rationalise cleaning, but nobody appears to have done an equality assessment. Nobody's looked at impact. These women will be extraordinarily vulnerable in any privatisation. The HSCB is currently tendering the work of a number of offices outside trusts, including subcontracted cleaners, where HSCB is taking no steps to ensure proper transfer information to potential tenderers. Again, we are going to organise those women because they're in a terribly vulnerable position. So if we look at the whole range of contracting, we find subtle, ongoing processes of privatisation that affect the most vulnerable in the society.
And there's also that fear, and again, it's because we're further removed from the decisions being made, is when you see changes happening to services, the fear is that that's ultimately setting them up so somebody can come in and take that portion of the service, the way that they're being packaged, and there's other things that are coming to the fore that could be causing concerns on that as well.
Okay, thank you.
I just heard reports today of something maybe happening in medical laboratories. Our colleagues who are working in that field shared it with us today, so we'll have to watch this space. No doubt we will bring it to your attention if it comes to the fore.
Thank you. And Michael, next.
Okay, thanks, Chair, and thanks for the presentation. I'm sorry I missed the beginning of it. And it's quite a sobering presentation. We had something similar from BMA, from RCA, and from also the midwives. So things are far from easy. As far as the structures are concerned, we'll talk a wee bit about the structures of the health service shortly, but can I say that from my experience, the department's not there to run the health service. That's not its job. The department there and the civil servants are there doing their job, which is policy, which is supporting the minister in terms of questions and debates, etc., and also in terms of managing the money that flows through from the Department of Finance in through down to the trusts. And the key instrument in all of this for managing is the Health and Care Board. Supposedly, there is supposed to be a trade union representative on that board. It was Lily Kerr. Who is it now? Nobody now.
There is no non-executive director from a trade union background, Chair.
Well, that is a vacancy that's still sitting there.
No,
isn't it?
Vacancy, it's been filled elsewhere.
The Minister plus one, Minister Boots, filled that with somebody, I think, from the financial background, financial sector.
Well, the key thing is this is a team game, as we're all aware. Everybody's on the team. And on the board, we have a doctor, we have a nurse, we have a pharmacist, and we had a member from staff side. So the member from staff side has been... All right. It's just...
How did you let that go?
Pardon?
Sorry.
Sorry, how did you let that
No,
go?
we didn't let it go. We objected and raised complaints, but sometimes you're talking to people who don't want to hear you, never mind.
Sorry, Mike.
Okay, sorry, Michael.
Well, sorry, an aside issue, but for the record, I mean, my own organisation had to take a judicial review because of, and the judge ruled that the minister had acted unlawfully in not appointing a trade union nominee to a trade union seat, and that was in the Northern Ireland Social Care Council,
Yeah.
for the record.
Okay, but you still have representation on Public Health Agency
Yes.
Yes.
and the BSO.
The term of office are about to come to an end.
Yes.
We are very nervous about whether either the individual or the trade union seat will be renewed.
Okay. Thanks for that. It's just for my own information. You said too that the key things you're saying to us, Jonathan, I think is firstly of all unmet need. That's the key thing. What is the unmet need? Because that's people in pain and distress and coming to harm. Those are patients that are falling through the net. And the other key thing I think you say too is how many people are needed to do the work. Because it's an issue. You have to have the workforce in place to actually meet the demand as it reaches you. Have you any sense of where we are in terms of the workforce from your side of things? We've heard from BMA. They're very, very nervous. We've heard from RCN, very, very nervous. We've heard from midwives, for example, again, very, very nervous about current situation and what's coming. And it seems to me the first thing we have to do is get a bit of stability, stabilise the situation before we take ourselves back to where we want to be. Have you any sense of where you are in terms of that workforce?
I think the first precondition is to have a stable financial platform that actually is measured against need. We haven't done that, and the tendency is increasingly not to do that, and that causes us great concern. I think we also need confidence-building messages to workforce rather than you're the problem. So, for example, when every trust is meeting the minister's sickness target, the immediate approach is to say we want to get even less sickness. You know, we've done really well on that, and we're not celebrating achievements like that every trust is within the minister's sickness target. I think we need, obviously, this process of modelling and workforce planning with trade union input, but it needs quick moves to some proper ratios and staffing models that aren't there. And the one, of course, we would highlight today is the absence of progress on normative nurse staffing, which is a critical safety issue in wards. We have the guidance of the Chief Nursing Officer. We have the guidance of the National Institute of Clinical Excellence, which in my view is much more rigorous and better. But we are not applying that guidance, and the reports we get are of notes of concern under the process being effectively ignored. So members are saying to us that we put in the AI note and nobody ever comes back to it. We've even had to set up courses as Unison to teach our members the law of whistleblowing. And this is the ongoing issue we now face.
That's unsafe staffing levels,
Yes.
nursing staff
Yes.
at wards,
Yes.
which by definition puts patients at risk.
Yes.
I could give you a competence building measure that could be undertaken, which is pay the staff their pay increase
Yep.
and pay them as per minimum the pay review body, and not slavishly follow that which Tory, the Lib Dem coalition undertook in England. We are now the worst. I think we are in the poorest position across the four jurisdictions in the NHS. Now that won't be resolved at this table, but any influence you can bring to bear on those who hold the purse strings, Department of Finance and whoever's managing the Department of Health at the moment, it's very, very important, because believe you me, the morale of the workforce and the annoyance of the workforce, and as what has happened, is increasing and accelerating. So there's a measure.
Okay. Oh, well, I wouldn't disagree with that. I'd be, certainly agree strongly with that. As far as the department's finances are concerned, however, the 2011 budget massively undershot what was required, and we provided the need. And it was about, as I recall, 4.8, 4.5 was delivered, and that is clearly not enough. And as a consequence, we don't have a workforce that's large enough to deal with the need. Therefore, we're getting large amounts of need, unmet need. And the longer this goes, the worse it gets. Where are we now, do you think, with the department? Because I understand we're back into the situation of overspends and drastic action being taken to get our budgets into line, as opposed to getting our sick people into line, or getting
290 million approved.
The system started this financial year, Chair, 31 million in deficit. One of the trusts has a 7 million deficit, which will have to be rolled forward into next year. One of the trusts actually made 2 million. It was immediately taken away by the department to meet the medical negligence claims. So the system is starting in deficit. It will be worse because of the failure to meet the savings targets I referred to earlier. So that takes us up to 60 million. We saw this pattern last year of escalating deficit and trusts being in deficit, because it's very clear that each of them are headed for substantial deficits by the second quarter. So we cannot just go on, I suggest, relying on monitoring rounds and sticking plaster to keep this going. It's fundamentally unstable, and as indicated earlier, the HSCB non-executive shared our view at the last meeting that we are at the cusp of risk and of compromising patient safety. So it is time not just for the radical action on the structures, but to rethink the financial platform, not only to deliver what we do now, which is under pressure, but to deal with unmet need and fundamental health inequalities. And we were very concerned in the last ministerial direction, the detail of the previous one about the specific actions to reduce inequalities was removed. We just had a statement about health inequalities, full stop. So we don't appear to have a strategy linked to finance and linked to performance to get those three issues right together.
Okay, thanks for that again. And the key instrument for management is the Health and Care Board. That's what was set up for. I set it up. I'm guilty. And I set that up, and I brought 4 boards into one, and that was to be the key instrument. And we had I actually said that under no circumstances go over 400 in that management. And when I left, it was 352. I understand it's now 525, and it seems to be loaded. How effective is that board in Exeter? Because the deal was the department comes out of running the health service. Civil service can't run a health service. And that therefore you have to have a management function, and the board would be the management function, and they would take the burden off the trusts, and that would allow you to reduce management function in the trusts, and that would also allow more money going into the front line. How effective do you think the board has been? You'll give me an honest answer.
Well,
We debated this earlier at the start of the meeting, but
Yeah.
I
I'll
mean,
repeat what we said.
I would draw attention to the York University evidence, which shows this sort of system can generate up to a 15% overhead on the unit cost of a treatment. Now, what we have at the moment is the Donaldson review. We have the department's review of commissioning. I gather the chief exec of the Health and Care Board has just been shown the terms of reference. We have the Health and Care Board's own review of commissioning. We have the department's review of administrative structures. I think in Russian the word is maskirovka, distortion, deliberation and confusion. It's a masquerade. We will not address the fundamental issue of how we commission and deliver services with the current disparate review process. And I think that process has to be challenged. It's not time limited. It's taking the issue away into the comfortable world of having reviews.
Of yourself and oneself and one structure, instead of somebody or a body or a review being taken at the whole service. And we thought we were getting somewhere with that conversation with Minister just departed, but the one before, and much we would disagree with him on. There's an awful lot we would disagree with him on, but the one thing he didn't do was sign off the budget, which was in crisis. Perhaps he was talking to yourself at the time, I'm not sure, but it didn't.
Sadly,
he didn't do that. But then that kind of, you know, momentum around maybe, look, we need to look at the big picture here seemed to dissipate, and then the directive came down, balanced the books, and there was a scattering. And then we just got all these decisions about cutting cloth to suit measure. And the crisis deepens. It actually deepens.
Sorry, can I make 2 observations? I mean, obviously, the establishment of the boards were broadly supported as part of an RPA phase 2, and we wanted to see them fit for purpose. I have observed that the difficulty you then have is the Public Health Agency is there to commission the services on behalf of the population. The board is to do the commissioning plan. It sends the plan up to the department, and the department says we don't have any money. And you know, we're seeing these this cycle being affected. But equally, I suppose the other most important point is if you remove it from the board, someone still has to do the commissioning.
But you see, that's actually not how it's supposed to work.
Well,
the Public Health Agency
observations.
Not there for commissioning. It's supposed to be the board. And the board, effectively the board tells the trust, here's what we need you to do, and here's the unit cost and so on. This is not a rocket science. You know how many hips you're going to need this year roughly, and you know how much it's going to cost, you know how many hearts, you know how many domiciliary care packages, and that's what the board's there to do. And we did away with 4 boards and we got 1 board. But what I'm detecting from you is that the department is still at the old business of trying to run the health service.
Yes.
And that overrunning the board, and the board doesn't appear to have the authority that it should have around the trusts, and therefore there's a general confusion. Everybody appears to be chasing tails, and it appears to be fairly confused.
Yes, I mean, Chair, I have attended the last 14 public meetings of the Health and Care Board to find out what's going on. I am the only member of the public present. Nobody engages. Sometimes we take speaking rights to try and change things.
I was with you in December.
Yes, I agree. So it was 2 of us present at the Health and Care Board meeting. It's got no resonance with the people. It's got no resonance with confirmed organisations when it's the decision maker on commissioning.
Yep, that's the
And that absence of resonance is leading to such frustration out there from all the organisations and groups that are seeking to improve healthcare. We're actually training up the Bangor protest movement to address their next meeting. We think they need livening up a bit.
Okay.
I think
Thanks.
Claire just wanted to
Yes,
ask.
Claire.
I was just going to say as well that I think if you want to look at how effective the board is, you need to look at what it was set up to do and then the delay with everything. And I think it does come back to that commissioning provider split, that we have this dilemma that we often don't get a commissioning plan until, I mean, I think the worst we've had was it, were we almost a year?
Over you.
That's
So
hopeless.
how can you deliver a service, and it's that
You can't,
split that,
yeah.
that you've got trusts trying to continue to deliver without actually knowing what budget they're getting, because the commissioning plans, I mean, even now we're not going to have the commissioning plan draft until next month. We're already a month into the financial year, so
Crazy.
we're already behind in the process. And I
We're
think
reading
there's only
between the
been-
lines. What they're doing is they're waiting to see what money is going to be available
Yes.
to add to the commissioning plan, and then they're saying, as you're saying, then it's you are commissioning according to money and not according to
Yes.
need.
I would add the observation
That's
that
why it's late.
you would always need to have the department which has responsibility on the part of the legislature to implement oversee the service. What you have in relation to the Health and Social Care Board is a big bureaucratic structure,
Yep.
as distinct from a function. And there is a debate to be had about housing that function much closer to the service providers who are the trusts.
Yeah, it's supposed to be like that.
When I first came to work in Unison, I kept meeting people who were directors of this and directors of that in this room. Then I went into another room and there were directors doing the same thing, but they were at the level of the service. So you duplication and, you know, a structure which has grown, as you've indicated by your comment, the figures, far beyond the original intention. So I think the function of commissioning must always be there, obviously, but it's how you actually construct that. And what you have is a bureaucracy now.
And you start with need.
And it's costing too much.
And the added layer with everything that TYC added in of more bureaucracy.
Oh, we've more people appointed. Some of them paid out of the 25 million. I didn't know what they were doing, but there you go.
Just to amplify, Chair, the PHA has recently been through agony about meeting the departmental call for a 15% budget cut. Intense debates. HSCB, in a finance report lasting 3 minutes, handed 15% back to the department without blinking. Something has been profoundly wrong about the balance of funding in various parts of the health service.
Okay, thank you, Fergal.
Well, thank you, Chair. I think the point was made last week by Michael, Chair, that, you know, there is an emerging picture. Normally when you look at some of these things, you know, you expect stakeholder criticism from their perspective on the production line. But what we're hearing here from all the stakeholders is that the production line is bust. If that's not undermining, if I don't mean that in that language, production line, but you know what I mean. The stakeholders are viewing the system, it's broken. Yeah. Just a specific on your last meeting with the board, how can they mark, or your interpretation of how they mark the TYC now to be at green, in other words, doable, in the context of what our discussions?
The tough and, in my view, quite right-wing member who replaced the trade union member asked very challenging questions about how we'd gone from amber to green, particularly when the unit was to be broken up, the post holder not replaced, and the whole function moved elsewhere with minimal investment. So there was good criticism from non-executive directors. At the end of the day, the non-executive directors on that and the trust savings required the board to write to the department expressing concern. But the green was seen as quite extraordinary, and you could see the looks around the room.
And just to interrogate that particular point about the group being split up, that's the TYC group. Is their understanding that's now going?
Yes, the unit is to be restructured, to use the euphemism. The function is to be mainstreamed into the work led by the Director of Commissioning. So that's the general commissioning process, including the commissioning plan, is now to include TYC.
That's right.
Under pressure from the non-executives, there was an agreement to continue with what's called the TYC highlight report, which is the where things are or not, usually not. As I said previously, I really await with interest the report on where we are with the 99 original proposals.
And what does that say to you about the last 3.5 years of being persuaded around TYC?
I think, Chair, we've been trying to achieve something that we are not funded to achieve. There's not been the hard realism that I would have expected, may not have approved of, within the project. And I think Liam Donaldson is absolutely correct in his report in saying there's not been the pressure, not the drive to deliver. But maybe this, rather like what I referred to earlier as the sanitisation of targets, is part of a sanitisation strategy to appear to be moving forward. I think we all have to, and that includes union members, acknowledge how desperate the situation is and the need for fundamental other directions to move forward.
So it's been a bit of activity disguised as movement?
Particularly, I would suggest, Chair, in respect of the integrated care partnerships, where we have still not had a response to our request to see the plans for the ICPs as approved by the board.
We've asked about 2 or 3 questions and that I still can't get an answer. We get some general headlines about what they're all at.
Yes.
So with no drive and with what you're saying, I'm now suggesting no plan, how do we transform the health service?
I suggest, Chair, we start with inequalities, As I indicated earlier, we identify the unmet need. We then match that with the existing and need for performance and care, and we match that with the sustainable financial platform. I've recently been looking at an outstanding piece of work by two economists, David Stuckler and Sanjay Basu. It's called The Body Economic. It provides the most convincing evidence going past down the last 100 years. If you have a crash or a recession, you either pump prime, I dare to use the word Keynesian, direct healthcare, or you do austerity. And it provides the compelling evidence that austerity damages health and damages health inequalities. It appears that that compelling evidence, the book was published 3 years ago, has been ignored by policymakers and governing politicians at all levels of the UK.
Okay, I had a specific question, but it disappears in the midst of that big strategic thought. Chair, I think we're at a pivotal moment here, and that this committee has got to take this all seriously. I think we've got to sit down and assess where this whole process is going, because, you know, almost like EYC somehow now either does or doesn't exist, and we have no measurement. And that's the questions that we asked at the start about this. Where was the measurement? Where was the implementation? Where was the money? And they spent a year and a half or 18 months trying to pretend that there was measurement, implementation and money. And it hasn't been there, and it clearly hasn't been there. We've wasted another year and a half. And I just think that we as a committee have got to reconfigure some of our approach around this. To interrogate the department about where it plans this health service to go.
Chair, if I may just
Go ahead.
comment. When we first heard the presentations on TYC, I remember being in a room, and Permanent Secretary at the time, I asked the question, is this the Lansley Bill or Act as it became? To which he said, absolutely not. And then we got the document, and it was just like somebody had taken that approach to the NHS and looked at the difficulties financially, put the two together and presented and landed on top of Northern Ireland this view of how the health service should be developed. And we're dealing with the fallout of that and all the crisis that has emerged as a result. I repeat the point, I think that in this place, with all of the politicians and the goodwill that there is towards the health services across all parties and all interests, could come together and do something different here. Do something different here in conjunction with ourselves and with other representative organisations to rebuild. And rebuild on those founding principles of the NHS. I mean, there's a big transition going on across the water, but it's opened a very serious challenge. And sure, look, it isn't the whole election process there revolving around what happens to the NHS. So it is the issue of the moment, you're quite right. And I think that we could do something fairly significant here and innovative, and we could work together, and we're up for it, we're willing to do it. And I think every organisation representing staff who came before you and gave evidence to you is of the same mindset as we are, and we could look to models elsewhere in the devolved nations and see what we can do.
And based on the evidence, that is the factual evidence, not just the evidence as presented. Chair, this job's too big for the department.
Yeah, well, look, I mean, there is a pattern. All of the evidence that we've heard to date has been similar. And there are challenges, very clear challenges. And I think when you listen to things like risk to patient safety, I think when you listen to the amount that was taken back off trust savings plans, as they're called, and delivery plans, I mean, I do think that we are at the stage where the hard conversation needs to take place about the model that we need to move us towards a public health model that actually targets health inequalities. Mm-hmm. And what is the system that is required to do that? Because it's very apparent that it is not the current system. The current system, and I said that in my opening remarks, is not configured to be able to deal with the challenges and need that exists within our society. So We are, and we will be, and rest assured of this, drawing up recommendations on the back of the evidence that we've heard today, and previous evidence, and evidence in the next number of weeks, with clear actions coming from that, and be reflecting. There's a number of actions that I've noted down. I would have thought that a vehicle like the Partnership Forum would have been the model to actually have that hard conversation. In relation to the type of model that we need. So it is time for delivery on it, and thank you all for your attendance, participation, and we will keep the conversation going.
Thank you for the time you gave us good airing today. We do appreciate it.
Thank you.
And if I may be so bold as to leave some reading material.
Absolutely.
Sorry, Chair, I missed the deadline for the submission, NIPSIS submission, but well, Chair, I apologise, but there's copies here, or I'm happy to send them to the clerk.
Okay, if you want to leave some copies here, and then we can circulate them as well. Okay, members, thank you for your attendance. Members, moving on to item 6, which is the
Thank you.
supported living for older people. Just advising members, departmental officials are here to discuss the department's approach to the committee's recommendations following our review of supported living for older people in the context of TYC. We're just waiting to change around the top table.
Tragedy because to get it back, just lose the 300 million a year. It's about the investors needing to get it back.
Okay, folks, you're very welcome.
Thank you, Chair.
Thank you. I'm sure you found the previous session and informative. We have Chris Matthews, Director of Mental Health, Disability and Older People at the Department, Kevin Keenan, Assistant Director of Social Services, Older People and Adults at the Board, and Shan Scullion, Acting Director of Elderly and Community Care Unit in the Department. You're very welcome, so I'm just going to invite you to make your opening remarks, and we will open it up to questions or comments.
Thank you very much, Chair. We're here this afternoon to provide an update, as you said, on progress against the recommendations that flowed from this committee's review of supported living for older people. I'm not going to take up too much time with introductory remarks at this stage. The detail of our update is in the paper, and we'll just take questions and all of that at the end. In the paper, we provide an assessment of where we currently are against the recommendations, as well as some background on 2 issues which are linked in this area, namely the DSD review of supporting people and the proposals for a phase 2 of the dementia project being taken forward as the Delivering Social Change programme. But I think there's probably a couple of issues it's worth making at the outset, just to help sort of frame discussion. I'm going to be using the term supported living and supporting people. DSD colleagues were very keen that I sort of define these at the outset. Supported living as terminology in sort of health and social care field is like an umbrella term for a package of measures which can include housing support, which also includes domiciliary care and supported housing. And the Supported People programme, which is led by DSD, provides purely sort of housing-related support. The aims of the approaches are very similar. The 2 supported living schemes are in fact partnerships between DSD and HSC, so I think there has been, as your review showed, a bit of confusion around how those 2 things interact. There may well still continue to be confusion, but I'm just trying to sort of clarify exactly how those 2 things sort of fit together. So in terms of the points I want to make before we sort of go into questions, I suppose one of the first things to recognise is supported living as a concept has proved to be very positive for the people that have lived in supported living schemes. I think it demonstrates very clearly the benefits of partnership working across different bits of the government and the HSC, and what can be achieved when you take resources from different bits of the system and put them together. One of the other strengths of the model is the flexibility. And I've visited 3 schemes since taking up post late last year, and they're all different in a number of ways, but the one thing in common across the facilities is that they provide a very positive and supportive environment for the people that live there, and all of the residents I spoke to were very happy with the situation they were in. And I think to an extent, as well as the definitional issues, the flexibility has caused some of the issues, which I think this committee's review highlighted and earlier evidence sessions highlighted around describing what supported living is and how it fits together and our approach to it. Because it extends across quite a wide client base, obviously outside the sort of older people. And it's, in some ways, it could be difficult to agree a definition which applies across the spectrum of clients, but obviously that's one of the things we need to address. And the existing schemes, because they emerge from the Department of Health, DSD, HSC and the Housing Executive, as opportunities arose, in some ways supported living is a product of a sort of bottom-up approach, and it sort of grew organically as opportunities arose in each trust as opposed to a sort of top-down model, and I think that's partially one of the issues, or partially one of the difficulties in terms of looking at it as a strategic issue rather than a sort of a needs provision. I think the other thing is as well, there are links into the TYC concept of home being the hub of care, and obviously sort of leaving the other issues which we just heard about TYC aside, the idea of home being the hub of care I think is a durable one, and one which I think we've shown in the different approaches we've taken to supporting older people as having a real strength and real demonstrable benefits. And as your report points out, our approach hasn't always been ideal and it has caused issues. And I think while understanding how we got to where we are is important, our focus now is on where we go from here. And as I said, our paper covers a couple of the big pieces of work in addition to this, to your review, that are really going to influence how we develop the policy. The first of those is DSD's review of supporting people, which is going to look at the current landscape, or is looking at the current landscape of provision. It's assessing whether needs are being met. It's evaluating how well the original policy aims have been delivered. It's also then looking at the strategic and legislative framework, and then finally it's going to take all of that together and make recommendations to where we go next. And the second issue then, as I mentioned, is the DSC Dementia Project, which also includes a dementia-specific supported living proposal, or a proposal for better sort of analytics and review. So more generally, I hope that our update on the committee's recommendations sets out clearly how we tend to factor in your views as we take this forward. If it doesn't, I'm sure we'll hear about it. As part of this, obviously, we need to engage with the key stakeholders that you reference and others. We need to make strategic links with other key pieces of work across the system, including OFM's active aging strategy. You've also correctly pointed out we need to improve our analysis and planning to underpin new schemes. I suppose just in closing, it scarcely needs saying the financial landscape is going to be very difficult going forward. And while there are going to be challenges, I think really what that does is to reinforce the fact that we need to work together on these schemes and get the best value out of our resources. And I think ultimately, sort of taking a step back just from supported living, our goal is to look for a spectrum of provision in which supported living has its place, but in which the HSE has the flexibility to meet the needs of older people currently and in future. So thanks for listening to my introduction, and we're happy to take questions.
Thank you, Chris. Just a couple of comments I have. First of all, the Delivering Social Change project.
Yes.
Is it older people in general, or is it older people with dementia? Or is it
Sure,
people
yeah,
with dementia, or is it all three? I'm not clear.
It's DSC is dementia specific, so that's going to include older people as well, but it may also include younger people who have
So
dementia.
it's people
as well.
with dementia.
Yeah, so
Okay.
it's specifically about services for dementia.
Oh, okay. But then I suppose in terms of older people with dementia, because increasingly, the evidence that we were seeking was actually indicating, we all know this in relation to the ageing population, we know it down to actually geographical areas and the increases of levels of dementia, but there's very specific needs in relation to older people with dementia. And are we suggesting then that the Delivering Social Change project would really provide us with that strategy, or a regional strategy or approach?
Well, we already have a dementia strategy which covers the sort of near term. I think what the Phase 2 Dementia project is going to look at is the sort of longer term issues. The issues you correctly identify. It's Phase 2, so Phase 1 is very much about current provision and dealing with the situation that faces us now. Phase 2 is about understanding the challenges that are going to be ahead of us. So we know, for example, by 2051, which is quite a long way off, but the number of people with dementia is likely to triple. So what that means is we need to start thinking now about the kind of radical changes we're going to have to make to provision to deal with that. So the phase 2 is really looking to the future, but it's going to feed into then how we develop a future dementia strategy and how we think about service provision in the future. But I think there is always that competing interest in terms of dealing with what you've got in front of you and dealing with the operational challenges you face on a day-to-day basis. But you need also then to create the capacity to lift your head up from that and think about, well, we know we have this big issue coming towards us in the future. We maybe haven't thought about it well enough yet, and that's really DSC 2 is what we're attempting to do.
But why would, and just for my clarity,
Sure.
I mean, why would that be the responsibility of a Delivering Social Change project?
That's a good question. I mean, that came out of discussions, I think, in OFM, DFM, and also the program is in partnership with Atlantic Philanthropies.
Yeah.
So I think part of it is it's something that AP were interested in. It sort of predates my involvement. It's something I sort of inherited when I.
But is it not something, in terms of a regional strategy for supported living or supported housing, is that not, the responsibility, for example, of the board or
Yes,
the
yeah.
department?
Yes, it is, yeah. And if the DSC project weren't happening, we would have to do it anyway. But it's part of trying to integrate our thinking around all of these different things. So it's about, I suppose, in terms of using the resources we have most effectively, so combining a number of different policy strands together so we have a coherent approach. But I think also if we have opportunities to look at things in partnership with other people and other experts, then we sort of take that as well.
So is there, but in terms of the Delivering Social Change, you're basically saying if that wasn't happening, the board or department, but who would have to do it?
Well, it would be between, in terms of supported living, it would be between the department, the HSC and DSD as well. Because
And then who, in terms of the monitoring of the project itself, is that OFM, DFM, or where does that sit?
It's, yeah, OFM, DFM monitor the programme overall, and we, on individual projects, report into a sort of central programme board, which is chaired by OFM, DFM.
Right, and then I noted as well, because part of the conversations that we were having was around the definition,
Yes.
or the lack of it, of supported living, and now the paper's indicating that the department will first consider how to reach an agreed definition,
Yes.
and then how to communicate it with key stakeholders.
Yes.
But I suppose one of our recommendations had been about involving stakeholders at the start of the process and coming up with the decisions
Sure. Yeah,
around
yeah.
the suitable definition, not just going in at the end and informing stakeholders, but,
Yeah.
I think it would be useful maybe to clarify that for us then.
Yeah, okay. So I suppose the first thing is that the DSD review, which looks at the Supporting People programme, is going to tell us what their view of supporting people going forward is going to be. And if it's helpful to think about it in these terms, the Supporting People programme is almost like the sort of bedrock on which we have built the supported living programme. So all of the schemes we're talking about are a partnership, which is primarily driven around the sort of housing needs. What the HSC brings in is the domiciliary care piece. So in terms of, in some ways, the issue around defining supported living is really a prelude to the policy on supported living. So in other words, we define what we mean by supported living in terms of the policy outcomes that we want to flow from that. So the DSD review is going to examine how the Supporting People programme has gone. Now, we are involved in that. But the Supporting People programme is much wider than just healthcare provision. So, for example, they will deal with homeless people as well. So what that process will do is really allow us then to understand with DSD, well, where is the emphasis of supporting people going to be, and how do we bring in the supported living policy, and how do we conjoin with that to ensure that our needs and their needs are met going forward. So Now, I can't prejudge what's going to come out of that, but some of the things, it might well be that there's a sort of a general agreement that it's worked well, and in our opinion, supported living is a good system, but it might be that the emphasis in certain directions has changed. So the emphasis might be more towards dementia, for example, or more towards other particular programs of care. And that would mean then we need to think about, in terms of the HSC, how we develop other schemes for older people and how we deal with the sort of TYC focus on keeping people in their own homes. That they're not necessarily ever going to be in conflict, and they're not necessarily going to rub up against each other. But I suppose the issue is it's a two-stage thing really. DSD will produce their report, and then we'll take that and we'll decide what that means for supported living. And in that second approach is where we will bring in all of those stakeholders and really say, this is what we think our policy outcomes ought to be. This is the definition we think gets us to that. Do you agree? But it is quite bureaucratic and it is quite long-winded, because essentially you're pulling together lots of different bits of work.
But is there room at that stage to influence?
Yeah, no, I mean, absolutely, because the supported living side of things, it's still our policy. I mean, it's limited on essentially where DSD go with their policy, but it's going to be a partnership. They're not going to do anything which causes us any great difficulties, and likewise, we're not going to run off to something that they can't support. But there is, essentially, it's a partnership between the two departments. And in some ways, because of the way it formed, which was really just out of opportunities that emerged from each trust, we're learning what has worked and sort of working backwards, as opposed to having a sort of top-down approach, which has its benefits, but also its disbenefits, as we've seen with the issues around the definitions.
Okay, there's a number of people who have indicated. Kieran first.
Yeah, Chair, thanks very much for your presentation. Just simply, I note the correspondence in relation to the recommendations from the department, which is fairly positive. There's only one there that concerns me, and that is recommendation number 8, where we suggested that you collect more data on the number of people. Yeah. And you've noted this recommendation and accepts the need for effective data. But then you want to say that the reasons you're not doing that is because it's resource intensive. I wouldn't have thought that if the trusts, they ought to have all of the information to hand, that it would be a significant resource detrimental to providing the data for which we would need to see well into the future.
Yeah, I mean, I can see where you're coming from, and the recommendation is the right one as well, because you're right. We do need to understand more. We need better analytics. We need better capabilities to project into the future. I think the issue we had there was more that trying to drive this through an analysis of domiciliary care provision. So I think there are something approaching 25,000 domiciliary care packages across the system. Trying to analyse those in terms of a person's candidacy for supported living or the suitability of supported living would be quite difficult when there may be other ways to get the same answer. And I think that's where the DSC project is going to look to see whether there are sort of proxy indicators or other indicators that are short of going out and sort of canvassing domiciliary care users. Part of the reason for that is the sheer scale of that and the sort of the resource intensity of that. But also, if you start asking people who are receiving it or in a program of care, and you start asking them about, well, have you thought about a different program of care, you might sort of unsettle them a little bit, because they might think, are they trying to move me on to something else, or are they thinking of making any changes? So, but in terms of the fact that we need to know more about it and we need to be able to plan for the future more effectively, absolutely. That is definitely where we need to go.
Right, okay. And just finally, is there any timescale? I think, did I hear you mention a date in the future where this will be all completed, our recommendations will be fulfilled, etc.?
No, we would hope to, in any future update, I think, be able to give you that. At the minute, we had hoped that the DSC report would have been available by now, and we would have been able to give you a bit more clarity. As we understand it, it's likely to come out in the summer. So that'll help us go on from there. The other thing is, because the DSC proposal hasn't been fully sort of agreed through all of the ministerial mechanisms, there's an issue around the timescale for that as well. But we would hope next time we give you an update on this to be able to give you more clarity about timescale.
That's grand. Thanks, Chair.
Thank you. Paula?
Thank you, Chair. I sit in DSD committee as well.
Okay.
So supporting people is something I'm here every other week. So I do. We've had many, many briefings, and as you say, it covers so many things.
Yeah, absolutely.
With homelessness as well, and it was really encouraging whenever Minister Storey took up his position. One of his first commitments was to supporting people, which is really good, and I think it shows a good, again, interdepartmental working amongst both, because it did up so much of the, I remember, of evidence we received in supporting people. Kind of thought, well, actually, that's more to do with health than it is to do with, with DSD. So it's good. I also like the fact that you mentioned planning for the future, because that's something that hasn't been done when it comes to housing in Northern Ireland. It hasn't been done for years, planning for the future. And I mean, we know even when we look at welfare reform, when we look at all of those issues, we don't have the suitable housing. As this also, we don't have suitable accommodation for people with dementia. So I absolutely welcome it. I think it's excellent. Whether we have Transforming Your Care or anything else, this is the model that people want. Never mind what a service requires. This is the model that they want. And Kieran has kind of asked most of what I wanted to ask, but where exactly are we? Where exactly, at what point are we at now that we need to then push for our next, to take this further?
Yeah, I mean, I think we are, I suppose, maybe creating a hostage fortune here, but I mean, I would say within the next 6 months, we'll have some statement of intent from the department based on what we know about the supporting people, and we should, within that stage, have more clarity around the DSE project as well.
When is the DSD one due to come to its conclusions? Do you know?
What I understand is likely to be the summer. So there's a delay of a few months there.
So we'll be looking then after summer recess.
Then we should,
with the definite plan of action.
So that, but what that should be then is a sort of a statement of intent that will be that process of engagement around, this is what we want to achieve. And I think one of the lessons for me in terms of the departments working together is that because this has been driven out of the people's needs rather than departmental policies, it's had a completely different emphasis in terms of how we put it together. So it's sort of come out of here's what we need to achieve for a group of people. Here is the scheme that achieves that for them. And then we've kind of worked backwards and, well, what does that mean for each of the departments? And in some ways, that's the way these things should be driven. But what it creates is then a bit of confusion as you work through, well, the departments have these very defined structures. These programs sort of cross over between the departments, but that shouldn't really get in the way in terms of what we actually produce at the end of it. But yeah, I mean, I think I would hope within the next 6 months we'll be coming back and saying, here is where we're heading with this. Here are, there are a number of schemes already sort of in the planning.
And there are already some models of good practice.
Absolutely. I mean, you probably.
We went to visit. I know in the DSD committee we went to visit several supported living environments. And there were already some very good models.
And you come away with a sense that these guys know what works. And I think the flexibility is working with the different providers who all have different expertise in different areas. And they're so much more agile than the departments are in a lot of ways, because they can see solutions and they can reconfigure themselves so much more quickly than the departments can. So there are a lot of benefits, a lot of positives in the scheme. And it would be a shame then to allow the sort of bureaucracy that then sort of gets caked on that to take away from the fact that the supported living approach has worked very well for people. So I think it's really, the challenge for us is to harness that and to not allow the bureaucracy then to get in the way of it, while paying due regard to all of the sort of due diligence and that sort of stuff.
I'm reading here as well. I know that you'd contacted all the trust to ask what their specific needs were, and but we are looking at a province-wide model, not.
Yes, absolutely. Yeah. I think we're looking for an outcomes-based model across the system that will allow the flexibility for each trust to meet the needs of its client group, but has basically a shared understanding.
Trusts are not really that different when it comes to client.
Well, yeah, I mean, there's a commonality, but I think it's just that we have an agreed understanding of what we're trying to achieve with it, how it's appropriate. Because the supported living schemes for the right client group are extremely effective.
Yeah, yeah.
But you need to make sure you get that right, because there could be people who would benefit from being more independent, who shouldn't go into the schemes and would actually have a sort of better life outside a scheme, and people who actually need more support than a scheme can give them, who shouldn't be. So part of it is understanding, well, what is it we're trying to deliver with these schemes? And as I sort of said at the beginning, to understand what the spectrum of provision is and to make sure that everyone, the trusts all have the flexibility to meet the
And I
needs that are
suppose that's
presented.
coming in from the Chair's point earlier, the consultation, if it's a wider based consultation.
Yeah.
Because the trusts aren't always the best place to say this is what, you know, we need. It needs to be a wider consultation.
And I
to
think
what's required for the people of Northern Ireland.
And that has been, I think, the benefit of bringing the housing associations into this, who all have their different sort of expertise. You're learning from what they're doing and some of the things that they've done. One of the schemes, which it's in a different programme of care altogether, on the Ormer Road, the Large scheme, what they've been doing in sort of conjunction with people who have learning disabilities and people who are homeless, the benefits across those two groups have been enormous, and everyone has benefited from it. But it's the sort of thing that only happens when you have that kind of flexibility, and it's the sort of thing that if you were driving it from the top might not have happened, because the processes within government are sometimes too inflexible. I mean, not to do us down completely, but I think there is a definite benefit to the way this has come about, and it's that kind of thing, that flexibility.
It's great. Look forward to September. Sure. See where we are then.
Okay, thank you, Fergal.
Yeah, I might be repeating the point, but could you just outline exactly what are we getting in 6 months' time?
So in 6 months, what we hope to be able to do is to give you a general statement of the outcomes that we want from supported living, how we see it fitting into the wider sort of programme of care for older people, and then also to overlay on that, if we can, what we're looking into the future as well, the issues for.
So we're getting a kind of a statement of intent, and then a plan for a 3-year project of analysis.
Well, the analysis will be a sort of a separate thing, sort of specific about dementia and provision in the longer term for dementia. But I think in terms of supported living, it's really just to, in the immediate term, deal with the uncertainty around what we mean by supported living. And I think a lot of what came out of earlier evidence sessions and this committee's report was, you're talking about this thing called supported living, but you don't seem to know what it is. You can't explain it to us. What we hope to be able to do once the SD have finished their review is say, here's what we mean by supported living, here's what we want to achieve with it, and then from that will flow the sort of policy and operational consequences.
On to the 3-year project. I mean, 3 years doesn't suggest urgency to me. Does it to you on the dementia project? On the and we welcome the Atlantic Philanthropies consideration, but does 3 years suggest any urgency?
Well, I think there is an issue about the sort of the timescale we're looking at. So if we're thinking in sort of longer blocks of time, then 3 years is probably not that long a period of time. But would we like to be moving forward more quickly? Sure.
Why aren't you?
Because I think there are some very difficult questions in terms of the analysis and the information available and the sorts of data schemes that we haven't set up yet that we need to establish. We don't really have a good understanding, as we discussed earlier, about what information is available and how to analyse it. Because of the way these schemes have grown up and because they weren't a top-down approach, there hasn't been a sort of data model coming in underneath that as we would do with a more strategic programme. So we're sort of trying retrospectively to work out, well, how do we analyse this, how do we understand it more effectively? And that will, I mean, that in truth, that will have to happen for both. That will have to happen for supported living more generally, but also for the dementia programme more specifically, because we know we have a very acute challenge in dementia. It's a long-term one, sure, but we need to ensure that any steps we take now, any policies we develop now, set us off on the right track for that sort of 10 or 15 or 20-year horizon we need to be thinking about. But would it be better if we were further on? Absolutely.
And will that include a general assessment of older people as a group and their needs in the widest sense?
We have a separate programme of work looking at adult social care, again in the sort of longer term.
What sort of timescale is that?
Well, that, we are currently sorting a piece of analysis on that, which is going to look at the, that's again going to be looking at probably a shorter term horizon in terms of dealing with these reforms coming through in England and Wales. So we need to know what our local response is going to be to that, but also then looking at, for the same issues in terms of the demographic shift, what sort of things do we need to be thinking about now as a system to deal with the fact that the population of older people is going to grow fairly dramatically, but also the working population is going to get smaller. So the things that we're doing now probably aren't sustainable 10, 20 years from now.
And Anna, the conversation which took place before with the unions, I know you were there for.
Sure.
Forgive me if you think this is unfair as a question. Tell me if it is. But are you doing that now in the context of TYC, or what plan are you doing it against the backdrop of?
I think TYC does have an influence on our thinking, in the sense that the home is the hub of care idea. Now, you could say, probably truthfully, that you can extract the idea of home as the hub of care out of TYC, and it still remains a valid model.
Yes, but what targets and measurements are you putting that against now?
Well, I think that's part of one of the recommendations is how do you set targets, and I think we're in the process of working through getting the data for that. What sort of targets do you need to set? What sort of targets are going to be helpful in the context of getting people into the right program of care?
Targets are important, and reporting to people about targets is important too. So is the TYC team being dismantled then?
The TYC team in the board.
Yeah.
Well, if I understand correctly, it's a mainstreaming process rather than a dismantling one. I mean, this is not my TYC, is not my area. But
forgive me if
and I'm sure you're going to write to the department about it. I mean, what I would say is that mainstreaming is not an uncommon way of making sure that sort of core principles of any piece of work are embedded into sort of operational delivery. So as a model, it's not necessarily, and you may agree or disagree with that, but as a model of making sure that something which has been sort of strategically agreed is delivered at the front line, mainstreaming is a fairly common way of doing that. But on the specifics of what's happening with the TYC team.
Okay, I know, and I'm conscious that it's not fair maybe to ask you, given the chair, on another thing, so we'll interrogate that further in the future. Okay, thank you.
Chair, just on a point of clarification, Transforming Your Care team is still in existence. It is still progressing a range of initiatives that were contained in the report, and they are currently doing a stock take of all of the 99 recommendations and where those have progressed to. So the team is still there.
Okay, has the vacancy been filled in relation to the Ms McCready?
In terms of oversight responsibilities, there have been discussions within the board, and my understanding is that Valerie Watts is taking oversight of that function within the board in the short term. And then obviously all of that will be in the context of the review of commissioning. So we await the outcome of those processes. But the TYC staff are still there, still badged as TYC staff, and they're still progressing the initiatives under that banner.
Okay, and there would be no concerns that a chief executive of a board to take on a strategic direction and oversight of a key policy piece would be feasible?
Well, the portfolio of the TYC team is very clear. There are a whole range of initiatives that they're taking forward. They have staff who have got responsibility for those pieces of work. They work very closely with people in other directorates within the board as well. Very many of those pieces of work are well under control. So basic business as usual.
Yeah, so you're indicating there's no risk, despite, you know, what I'm not getting into the previous conversations, but despite the evidence base that is increasingly gathering around how we almost inject or resuscitate almost Transforming Your Care. There's no risk in your view. You're saying it's business as usual. There's no.
I have a very simplistic view of Transforming Your Care in the sense that the original report didn't pretend to be totally new. It attempted to capture a whole range of initiatives and strategies that we have been wedded to and signed up to for many years. And if we did away with Transforming Your Care tomorrow and we started off with a blank sheet of paper, very many of the projects enshrined within Transforming Your Care would be back on our agenda because they are manifestly the right thing to do. Fergal's question about dementia. Dementia is writ large within Transforming Your Care because the client group arguably that Transforming Your Care focused on most was older people and the challenge that they pose in terms of meeting their needs. And one of the biggest challenges within the older people's programme is dementia. Absolutely up there, right at the very top of the list.
Yeah, I know it is, but just Chair,
Sure,
back
go
on that
ahead,
point,
yeah.
we're looking at a 3-year plan to assess some of the needs around that. And I mean, if we want to translate it down, a board commitment of £8,000 a year towards over 3 years for a plan isn't telling me that you are heavily committed to this. You're fair enough, you're bringing in money from elsewhere, but that's not, it doesn't signal to me that level of strategic direction.
Chris has talked to yourselves about the dementia strategy. It's only come out, I think, a year and a half ago, 2 years ago. We were mandated to take that forward. There's the work that we're, I hope, fortunate to be able to benefit from the DSD. But predating all of that, planning processes are in place. There are facilities in train. Facilities that you have visited have opened in the interim. Some of those have been focused on the needs of people with dementia. So don't think on the basis of this discussion that it's all up the road and it still has to happen. It's happening out there
No.
in real time.
Yeah.
And our trusts have been progressing those initiatives for years.
No, I understand that, but we're also seeing scenarios where people with maybe starting in dementia stages and who are getting care in their home are getting what one might feel is inadequate care in the sense of time allocated to them and the stress that those domiciliary care workers are facing as a result of it. So there is an urgency to try and find out, to scope out the demographic so that we can actually scope out the need. And I'm only suggesting that a contribution of £8,000 from the board over 3 years each year isn't saying to me that that's the big strategic piece. I just, and the fact that it's taken 3 years, or will take 3 years to do it, when I think there is an urgency to try and fast-track the data collection and understand the direction that we're going in. TYC was supposed to be over 5 years. Now we're starting scoping exercises which start now and will take 3 years. And I'm assuming, and I respect what you're saying about other actions, of course, occur along the line. I'm not really saying that nothing's happening and only the starting line, but in terms of informing ourselves, getting best value, getting best outcomes, fast-tracking the information and the data gathering might be an indication that, in fact, we would have quicker action to follow. That's merely the point.
And I think it's probably fair to say that from where I sit, I think the publishing of the dementia strategy has added impetus to the work that's been done. And as I said a few minutes ago, I think the fact that Atlantic Philanthropies have taken a very particular interest in this, they're providing funding, they're making sure that we work very closely together with a sister organisation, I think that will add more impetus to trying to address the needs of arguably the biggest challenge that certainly I face in my work and life, or even the board faces in terms of the demographics that we're trying to address.
Okay, well, thank you all. Nobody else had indicated. So thank you for that update today. We'll be watching it.
Thank you very much.
Thank you. Okay, members, moving on. Item 7 is the Forward Work Programme. Just referring members to page 68 of your meeting folder and asking members to note the Forward Work Programme. Item 8, members, is matters arising, and there are 3 items under matters arising, page 72 of the meeting folder. At page 75 is the response from the Minister regarding the proposed shift of 83 million from hospital services to community primary services under TYC. And I think it is worth noting that the response now seems to have expanded the definition of shift left to now include new categories of what's been called avoidance of hospital activity and redirection of new investment into community-based transformational services. So the focus, certainly in terms of this response for 15-16, seems to be on the redirection of new investment into community-based transformational services, rather than any proposals to shift money from hospital-based services to community-based services. So it does, in effect, mean that the department seem to be spending money slightly differently, but it still seems to be within the same programme of care budget lines. I think we need to go back to the department on this and get clarification. I mean, when you reflect back on the commitment to the shift of 83 million, it seems to be a mess, in my view, and the department seem to be in a bit of a mess with this. I think we should seek clarification firstly on whether the department has any proposals for 2015-16 and beyond to shift services from hospital to community settings, or whether they've done all that they intend to do. And I think also, if there's no further shift being proposed, you know, what's the rationale for that decision, and what's the wider impact? Again, the question we're asking today, and in the last number of weeks and months, what's the wider impact in relation to the implementation of TYC?
Yeah.
Can we agree to do that? Nick Fergal wants to comment. Yeah.
Just on one further piece, given some of the comments that we've had across both sessions today, what is the status of the TYC team? But not just in the moment. What is the future status? Are there any plans? Questions sufficient for us to have some sort of an assessment going ahead 6 months to a year about where those TYC or where that TYC board is within the thinking of the department?
We have written off in the back of the evidence last week to seek clarification on the status, but I think it is important, and we should reflect it in this letter about the future.
Yeah, that was more
status.
of a policy piece, was it not last week?
Well, it was on the back of the evidence from the RCL and the Royal College of Midwives, that the question came up about the current status of TYC, so we have went back. But I mean, I have no difficulty with including that in this correspondence as well, in terms of future status. So are members in agreement that we do that?
Yeah. Just on that,
Sure.
letter, Chair, just a wee bit of encouragement. The pilot on diabetes is very welcome, and that we noticed there's 270 diabetes patients in the trust that are currently benefited from this innovative idea or project. So that's to be very much welcome and hope it can be rolled out.
Okay, point well made. Thank you for that. Okay, members, then, are members content to note the following, or the remainder of the item, sorry, under matters arising? Item 9 is correspondence, and there's 10 items of correspondence, and 2 items in your tabled folder as well today. Page 133 and 134 are correspondence from the Unison Community Branch and the Bogside and Brandywell Health Forum. Both organisations are requesting to meet the committee, and I'm suggesting that we invite them to the stakeholders event on the 20th of May. Great. Page 5 of your tabled papers is correspondence from NIAVE, the Northern Ireland Association for Mental Health, asking to attend the stakeholder event again on the 20th of May, seek agreement to invite the organisation to the event.
Great.
And page 6 of the tabled papers is a report on the conference the SDLP held in March entitled Care for the Future, looking after our older people. And the report reflects the concerns raised at the conference and distills recommendations from the organisations on how best to improve the system. I'm seeking agreement to note the remaining correspondence, unless members have any comments they wish to make.
Could I just make one? I would just urge members to take a look at that report, Chair. It brought together, it didn't ask anybody to come with a preordained outcome, but these are key stakeholders in the older people sector. And individually and collectively, they've all come to the conclusion that the system is failing our older people. And I think it's a valuable addition to our narrative, and it also distills, as you quite rightly say, some recommendations out about how the department might consider some of those issues going forward.
Okay, thank you for that. Item 10 then, members, is any other business? Do members have any other business?
Chair, there's just one that I just want to run by the committee, and that is, thankfully, the finish of the long-running saga that we had in the Flicks restaurant. That's been running for 3 years. I think it was even before your time as chair, which was concerning a lot of people, and it was a big outcry at the time, and it came through the committee. And, you know, just to put on record our thanks to the Food Standards Agency, of which we've spent a lot of time on recently, on food safety, and of course the Belfast City Council, environmental health people, because it affects us all. and lessons can be learned. Simple as
Okay,
that.
thank you for raising it. Okay, 11, date, time and place of next meeting, which will be on the 13th of May, starting at 2 o'clock in the Royal Victoria Hospital. The meeting will be preceded by a visit to the gum clinic at the hospital. The visit will start at 12 noon. Transport will be arranged from here if required, and committee staff will contact members with information on travel arrangements.